Okay. Well, I think we'll get started. Welcome everyone to this pre-conference webinar from IHA. I'm Julie McKinney. I'm going to be moderating the webinar today, and I will introduce our speakers, Lindsay and Jonathan, in just a minute. Very excited for this webinar. It's about multi-level health literacy assessment for families with children with complex needs. We're very pleased to have our speakers here. I'm just going to go over a few housekeeping instructions, and then we will give it over to them. So I've put in the chat to introduce yourself with your professional role, area of work, and your interest in or experience with health literacy. If you have any technical problems, I'm going to put in the chat the email to use for help. And Lindsay, if you can switch the slide over to the housekeeping slide, then we'll get this going. So you might notice you're all muted. So, and hopefully you're connected to the audio and can hear us using your computer speakers. If you're having any technical difficulties, I put the email to use in the chat box. It's conference@ihaforhealth.org. Just email them, and there are people standing by to help you. You'll be muted during the presentation. If you have any questions, please use the Q&A in the bottom right for questions for the speakers. You can please feel free to use the chat box to introduce yourself, to comment, to share information. But for questions with the speakers, it's a little easier if you can make sure that goes in the Q&A box, because then we can make sure they get to them. They will be answering questions at the end. And the presentation will be recorded and posted to the conference website by May 19th. You will have the slides and you will have the recording. So don't worry about the slides, you will get them. If you're requesting continuing education credits, there's two things you need to do. You have to submit a session evaluation after this session, and an overall conference evaluation after the conference. After this presentation, you'll get an email with a link to the session evaluation, and at the end of the conference, you'll have access to the overall conference evaluation. So those two things will be your ticket to your CE credits. I think that is all. So everyone's introducing yourself. Thank you. It's nice to see a variety of people here. And I guess we'll go to the next slide, and I will introduce Lindsay and Jonathan. So Dr. Lindsay Rosenfeld is a social epidemiologist with research, practice, and policy interests in the social determinants of health, child equity, and health literacy. She's an instructor in health literacy at the Harvard School of Public Health and leads research focused on families with kids with complex needs at Boston Children's Hospital, Harvard Medical School, and Brandeis University's Heller School. She's a longtime member of the American Dental Association's Health Literacy in Dentistry Committee. Dr. Jonathan Litt is a neonatologist and health services researcher at Beth Israel Deaconess Medical Center in Boston, and directs the NICU Growth and Development Support Program at Boston Children's. His body of research is focused on the long-term health and neurodevelopmental outcomes of high-risk infants and evaluating the utilization and effectiveness of community-based intervention services. Welcome, Lindsay and Jonathan. We are eager to hear your presentation, so I will turn it over to you.
Thank you, Julie, so much. Thank you for having us. We're really excited to be here. I'm really excited to have read so far all the different folks who are here with us, really varied backgrounds and experience with health literacy. So I'm excited to engage in our conversation today. So Jonathan and I have set up this agenda in hopes that in our short time together, we can cover a project that we worked on together, which was in the NICU grads clinic, which is a follow-through clinic at Boston Children's Hospital. So we'll talk to you a little bit about our approach, give you some description of the project, talk about what we did and what we found and what our key learnings are and what our next steps are, because as so many projects, especially in health literacy and working with families, with young kids with medical and developmental complexity, there's always next steps, right? There's always the next thing to do. And then we look forward to engaging in discussion and questions together. So, you know, we only have an hour. There's so much to dip into. This is a high level overview of some of the concepts and approaches we're using and of what we did, right? It's not a how-to workshop, but we hope to touch on some things that you might be able to use, maybe hopefully some new ones, and really focus in on discussion for action. There's a lot of resources that we've provided at the end of the presentation too, knowing that we've just touched on some things and can't dip deep into them. We've provided lots of follow-up and links, and certainly not the end of the conversation. I put my email in here and I can be in touch with Jonathan. I'm happy to facilitate that. I'm very excited really to continue this conversation. So today we hope you'll be able to define health literacy, describe how health literacy is interactive and multi-level and essential to health equity, describe components of a multi-level health literacy assessment, identify some assessment tools that you can use, explain, you know, how we're going to use findings to create next steps as ideas, because we're not totally finished. And then hopefully that this would be helpful in identifying next steps for your own work. So first, to talk about our approach. Jonathan and I met in an interesting way. And that is that I had micropreemies at 28 weeks who were born with many complexities, both related to micropreemie and not. And Jonathan was one of their early neonatologists. And then my kids participated in the follow-through program, which Jonathan runs, which is a post-NICU program. So we sort of started these discussions, given my professional background, while my kids were patients, and they've been evolving. And so this is work based out of that sort of initial relationship, and also really thinking both from a health literacy perspective, you know, a preemie perspective, all the things that Jonathan does, and also as a parent perspective, you know, bringing this all together in our approach as well. So we certainly have an approach that health literacy is health equity, and given that in context, right? So health literacy is in the context of all these other structural and systems perspectives, and we won't have time to dive into all the ways that we're applying these perspectives today, but I think it's really important context. Jonathan and I both see it as part of this work, and so it's important to point out that all of these factors, as well as others, are part of the ways that we're thinking about health literacy and multi-level assessment. So one of the ways is by using the socio-ecological model, which is a model that has us think about how children or families interact, and how children are nested within families, which are nested within the larger community, which is nested within all kinds of policy and law and decisions. And looking at each level, and these are just a couple examples, not exhaustive, of the way that the social determinants of health in this example affect equitable early childhood development, right? And looking at equity as a process, it's part of the journey, it's part of the way you set up getting to equitable outcomes, right? So it's the input as well as a desired output. And also thinking about all of these issues across the life course, right? So certainly what's happening prenatally, in the early years and later years, you know, all of these things may function differently at different points in the life course, and as a tool for family engagement as well, right? Thinking about where are the things across level that are important. Is it something going on in the community that's really affecting this thing that we're concerned about with the child? Is it something happening with the family? Is it in an interaction between the two? And how might that be different depending at which point in the life course we're looking at? So today, of course, we'll be focusing particularly on health literacy, but within this context. And we see health literacy as systems interactions. This is a framework put forward by Dr. Rima Rudd, which really shows health literacy, you know, as the center, as the crossover of all these different components. So we have skills, right? The skills of individuals as well as the skills of professionals, interacting with all the different text that we as families, as patients, as providers have to deal with, whether that's talk, whether that's a website, whether that's the information brochure, the patient history form, a medication label. And then there's tasks in healthcare, right? We don't provide information or talk or websites or a brochure just cause, right? We're certainly trying to inform, but often, most often in health, there's some kind of task, whether proximal or distal, right? Some immediate task that has to be taken care of. How do I get to where I'm going in the hospital based on the signage? Or maybe some more long-term task, right? Management of some kind of chronic disease or preparation for surgery. We also have all the emotive, physical issues, practice norms which come to this, right? How I might engage as a parent might be very different if it's my children or it's not. If it's something acute that came up, if it's a provider I've been to before and I have a little context already, of the field, right? Is it the pulmonary doctor or a brand new appointment in pharmacogenomics, right? And the emotions that I'm bringing to that, factor in, certainly. Also the context, right? The structural facilitators and barriers to interacting in any one moment or, across the journey. So some definitions, right? Literacy can be many, many components. There's reading literacy, right? Listening literacy, oral literacy, speaking or oral literacy, numeracy, and writing. And we're not going to dive into that much further, but really just to be keeping in mind, there's all these different aspects of literacy and literacy skills. And what we know certainly is that adults in the United States do not have the literacy skills, a large proportion of them do not have the literacy skills necessary to use the US health system, right? So this is a substantial proportion, which should say to us that all of us every day in our interactions with patients meet people and interact with people who are having difficulty because they don't have the literacy skills necessary to interact with the systems that they're interacting with. So just to give a little bit of history of how health literacy has evolved in the United States in particular, and very much why we take the approach we take, that multi-level equity, family engagement, integrated approach, is this really the evolvement of the field and the research. So early in 2000, arguably our first sort of public health literacy definition from Health and Human Services, we have a definition that focuses very much on the skills of the individual. This is closely followed up by Prescription to End Confusion, which was a major document that came out in 2004 from the Institute of Medicine, which said, actually, let's think about health literacy is that interaction, right, between individual skills and the system's demand on those individual skills. Then in 2007, we have the Joint Commission, the accrediting body for hospitals, saying health literacy and understanding information is a safety issue. And this really propelled the field forward because now we have this idea of universal precautions, which is well known in the health and medical field, and this issue of safety, right? And health literacy being essential to safety. This moves us to 2010 when we have the National Action Plan to Improve Health Literacy. And there we're seeing a national plan, right? So now this is a national level plan suggesting the things that we need to do as a nation to improve health literacy. About that same time, and then there was a revision in 2015, IKIRSCH, Agency for Healthcare Research and Quality, put out a health literacy universal precautions toolkit. We have links to all these things in the resources if you're not familiar with them. And these really gave a lot of assessment tools that hospitals, clinics, practices could use to really think about health literacy and this universal precautions approach. Then in 2012, there was a document that came out called the 10 Attributes of Health Literate Healthcare Organizations, put out by the Institute of Medicine, really saying our institutions, our organizations can be health literate. And here are those attributes to think about. Most recently, we have Healthy People 2030, and certainly there were earlier Healthy People definitions of health literacy, but this most recent Healthy People defines health literacy as personal health literacy, which is more individual skills, and organizational health literacy, which is again the idea that there can be health literacy of an organization. And there are those definitions. So what all this says to us when we approach this multi-level assessment and really saying, you know, we can no longer focus just on the skills of individuals. We know that significant proportions of US adults have underdeveloped literacy skills. We know that literacy skills are linked to social factors and health outcomes. We know that there's this mismatch, right, between skills and what organizations are putting out there. And we know that things are not becoming less complex, they're becoming increasingly complex, right? And if the pandemic has shown us nothing else, it's that. So what are the implications? The implications are health inequities, right? And our action to deal with that is to remove barriers. And so we really looked at this multi-level assessment as a way to approach and do what we've been told for years, which is this universal precautions approach, right? Which is to say that we're taking specific actions at many different levels to minimize risk for everyone. And that everyone prefers this interaction with risk minimized and with more plain language, right? And we're thinking about all these different literacy skills simultaneously. And we certainly have evidence that folks, and here's an example quote, you know, quickly we realize it's not adding more, it's learning how to do things differently. And this is a framework for approaching everything that we do. So for example, if we were to think about the family or the patient tasks just involved in a follow-up visit, this is, for example, a child with medical complexity, all the things that need to happen pre-visit, all the things that need to happen during a visit, all the things that need to happen post-visit, and all the different literacy skills that are connected to this, and all the different levels at which these literacy skills interact, right? Is this something an individual is trying to do, the family, and is the demand from the community? Is it clear where this place is that we're going in the community? Or in a telehealth environment, is it clear how to log on to telehealth? Did the text reminder I get say in person at X building? Because that's what the system usually says for that provider, but actually it's telehealth. You know, what are the forms looking like that I have to fill out? What are the materials that I'm getting, et cetera? So today we're going to focus particularly on only a few domains for action, right? All of these are relevant, of course, but today we're really going to focus in on the ways that we did assessment for looking at understandability and accessibility of information, and then the way that we did this for the health literacy environment. So Jonathan, I turn it over to you to talk about the project itself.
Terrific. Thank you so much, Lindsay. So our project has really taken on several different parts, and today we're only able to share just a piece of it with you, which is exciting, but just thinking about it's only a part of the story in this multi-level approach. To talk a bit about the context, though, so where did we do our project and our work? Well, it's in a follow-through clinic, or what sort of used to be called sort of NICU follow-up, which is a program for high-risk infants after they leave the neonatal intensive care unit. At our hospital, it's a quaternary academic children's hospital, and it's a specialized program for both medical and developmental support for infants at risk for developmental delays, chronic health problems, and neurosensory impairments. To be eligible for our program in high-risk infant follow-up or follow-through, children were either born under 32 weeks gestation or born between 32 and about 36 weeks, completed gestational age, with some other complexities. And we define that as either being small or low weight for your gestational age at birth, having significant respiratory, gastrointestinal, or neurologic illness or injury, or social risk as determined by the primary medical team at the time of discharge. Excitingly, we actually have a new program that I'll just mention here, is that we're starting to follow infants who have new diagnoses, genetic diagnoses in infancy that are associated with developmental delays over time. Our program is multidisciplinary and includes staff from neonatology that provides medical follow-up, taking the medical history, going over current medical concerns and conditions. We have psychologists who performed testing for language, cognition, behavior. We have a physical therapist who does testing for both fine and gross motor skills. We also have a social worker who helps support families, find resources, and do psychosocial assessments. Next slide, please. We've noticed, though, over time, both in sort of some qualitative sort of gestalt feelings, but also looking at some quantitative assessments, that there are varying levels of participation by families in our program, both at the outset in terms of who actually comes after being referred, but then also how many families actually stick with our program, continue to receive follow-up care through the first 3 years of life. In an internal analysis, doing some quality improvement work, we actually found alarmingly significant racial and socioeconomic inequities in our program participation. We looked over the course of about 18 months for 477 families who had been referred from our primary referral in NICU. 43% of white families attended their first visit, compared to 33% of Black and 19% of non-white Hispanic or Latinx families. We also found that families who live in high opportunity neighborhoods and child opportunity neighborhoods are those that have opportunity for both economic opportunity, employment for families, and education. Those from those high opportunity neighborhoods were nearly twice as likely to attend their visits compared to those in low opportunity neighborhoods. We also found that families who had limited English proficiency were also half as likely to attend their visits. This is consistent with existing literature describing the socioeconomic inequities in accessing resources for premature infants and children, and more generally for pediatric care. Next slide, please. So the work that we're going to describe is really a reaction to noting these inequities, understanding that we need to address them, right? This is an issue, this is a moral one. It also is a failing of our duties, I think, as pediatric providers. We applied equity frameworks, so thinking about health literacy, about racial equity, social determinants of health, among others, and to really go through in a systematic way to do some data collection and analysis. We analyzed documents using some tools that I'll describe in a few minutes. We also did a health literacy environment assessment using some really novel tools that I'm excited to share with you. I've learned so much about this space from Lindsay in doing this work. In addition to this quantitative work, we actually did some qualitative work, doing interviews with key informants, with staff members, and with families to really get a sense of what are the barriers and how can we address them. These analyses are in process. We'll share with you just a few of the themes that have emerged so far. We also had planned then to assemble a task force to review the results and to strategize for action to actually address what we found in terms of barriers. And then our goal is to implement small tests of change to hopefully lead to improvement in our primary goal, which is to be open, welcoming, and actually accessible to all types of families. Next slide. So to talk about our assessments and our results, first we'll talk about the document assessment, and we'll again review some of the quantitative analyses. And we had a great amount of help from graduate students in public health who were taking coursework in health literacy and really had a wonderful opportunity to do some hands-on learning, working with data in real time. We had another set of students help with our environment assessment, doing a walking interview and health literacy environment assessment. And then a further group of graduate students who've helped analyze the interviews that Lindsay conducted with our key informants and staff and families. So in thinking about, what are the tools and what are the learnings? What is the real goal here with doing these assessments? Well, we want to answer a few key questions. How can I determine if the information item that we're using is actually worth using? How can I develop an informative information item that's actually worth using? How can I talk with patients in a way that is most useful for them? So based on the tools and guidelines for information items. And how can I assess if the environment is contributing to positive patient experiences and outcomes? These are all questions that may sound quite intuitive. They might sound quite natural. But I have to say, as a clinician who's been working with this patient population for a long time, when we're creating these documents, when we're thinking about the health literacy environment, we're not always thinking about the user, right? How is the family going to receive the information? It really, from a clinician's point of view, it so often is, what is the information I think is important to give to the family, and not what is the information that families think is important to be received. Next slide. Some further guiding questions for development and assessment for tools. So what is it that people need to know? What do my patients and families need? But also, what do they want to know? And when do they want to know it? We also need to ask, what do we expect people to do? So is there an activity or a task associated with the information that we're giving? And is that clear? In addition, what materials and tools do we provide? Right? We have to sort of think about, are the tools designed to help with the task that we're actually asking families to do? Are the tools provided in clear format and language? And are the tools usable from the perspective of the users? Again, it's fine for me as a clinician to design something that I think is helpful, but if a family doesn't find it so, that really has missed the mark. We also really need to reflect and be very, very conscious in asking, will people with average literacy skills be able to use the materials or accomplish the task that we're asking them to do? Also, how are families able to navigate the environment or the processes? And really, at the end of the day, the real question is, how can we help? Next slide, please. So we'll go over sort of these two domains in describing the tools, the assessments, and the results that we found. First is the information item useful? And I'll describe some assessments that we did with a select sampling of written tools that we have in our program. The second question is, what are the environmental facilitators and barriers to positive patient experiences and outcomes? Next slide. So for the first part, we're going to sort of address the key question, is this information item useful? And the first set of tools, or the first tool, is the SMOG score, which is an assessment of the reading grade level of a given text. In this next slide, you'll see that we sampled really just a representative 9 different written items that we generally use and give out to families who come and participate in our program. And the SMOG score, it's a systematic way of assessing the reading grade level of a given text. And the number that you see in the chart here, in this box that's outlined in red, corresponds to the reading level, or the grade reading level, of a given text. Let's keep in mind that the average reading level for an American is 7th or 8th grade. You'll see here that each of these items that we typically give out routinely in our clinic is all well above that, right? The lowest grade level is about 9, and it goes up to 16. This was actually so eye-opening to me and the rest of our program staff, recognizing that the materials that we hand out typically to families are really well above where the average American reading levels and skills may be. Next slide, thank you. The next assessment we did was looking at both the structure and the format of our tools, and thinking particularly about the complexity of these tools. And the assessment tools used were the PMOSE and IKIRSCH, and it gives us a score that's related to the complexity of a given item. Here again was just a smaller subsample of the items that we give, the written materials. And you'll see this also corresponds to a grade level. And this particular tool gives you kind of a range. And you'll see here that perhaps it's a little better than the reading level, but it still shows a complexity level, particularly with number 8, the NICU CRAS referral contact sheet, right? This is sort of how we communicate first with families. It's at a complexity level that's aimed at high school, which tells us that perhaps some of our documents may be more complex than they really need to be. Next slide. Finally, we use the PEMAT score, which gives us 2 separate assessments. One for how easily understood or understandable a text may be, and another score for how accessible it is to a user. You'll see here in the red box, we have scores for 7 of the 9 sampled written items. And there's quite a range in terms of both the usability and the sort of actionability for these different items. None of them are very high though, right? Sort of the average scores are actually quite low. Again, telling us that the tools that we use, the written information that we give to families, though it may have the content that we think is important, it might not be actionable for families. So this really gives us quite a lot of information and tells us that there are some things that we need to do to address the written materials in our program. I'll hand it back to you, Lindsay, to describe the next piece. Yeah.
Thank you. So I'm going to talk about the 2 assessments that we did to understand what might be facilitators and what might be barriers in the environment to positive patient experience and outcomes, right? So we're looking not only at the materials, information, website, forms, and some of the charts that might be in some of those informations as Jonathan was describing, using the SMOG and the PMOSE, IKIRSCH, and the PEMAT, but also the sort of next level, right? All those information items are within the clinic and used by the clinic, but now we want to go up that next level and think about what kinds of things make the clinic navigable, accessible, and usable beyond the information alone. So we used the walking interview. Wait, let me just back up here. So the walking interview is my sort of favorite first try at thinking about the health literacy environment. And if you haven't used it before, it is all of these tools are free and accessible online, we should say, and the walking interview as well. And what happens is that all the directions and the step-by-step of how you do this is included in the guide and in the assessment. And then the actual doing takes roughly an hour. And it leads you through this exploration of the website, of telephone, as well as the arrival to and the journey in an institution to a particular destination. Unless you are an employee of the space or a patient, or you are inviting patients in to do this, which certainly is done, we always recommend that you only go to public spaces otherwise, right? So we're not going to an inpatient unit or some other private space like that. We're navigating to the cafeteria, we're navigating perhaps to X-ray, things that are more in the public domain. But certainly it can be done for anywhere, right? If you have the sort of appropriate credentials, right? We very much part of this is we're not in the way, right? We're not trying to impede flow of traffic or anything else in order to do this. So we are physically in the space. We're not going to talk about it today, but with my students this year, we had to adapt this for the virtual environment, given our context. So that's an interesting learnings I'm happy to talk about. But for this purposes, this was done right before the shutdown, so we were able to do this in person. So the process is that there's a guide and there's an observer. And the guide is leading this person in a way, meaning they're facilitating some questions. And the observer is not getting help per se from the guide, right? They have to figure this out. That's how we're going to assess how navigable is this environment. how navigable is the website? What do I learn from the telephone? What are the facilitators and barriers to my arriving to the front door of the institution, as well as moving through the institution? And the guide is making notes along the way and asking the observer to share their thoughts, feelings. What are you going to do next? Oh, you've run into a challenge. How are you thinking about, talk out loud to me, a little bit like a cognitive interview. How are you thinking you're going to take your next step? Why are you thinking that's the next step? So when we did the walking interview, we looked at, as I said, on the left column there, webpage, telephone, the walk to the institution, the experience in the entry and the lobby, and then the journey to the destination. So what we found when we looked at the webpage, and for the sake of time, these are very high level themes, but be that as it may, we found that the directions on the website to the clinic location were quite unclear. It's very hard from the directions that were provided on the webpage to know how to get to the clinic itself. Our telephone experience was a prompt system that was clear, it was friendly, though there were non-specific directions provided, when you sort of move through the prompt to figure out how to get to the clinic. The walk to the institution, we observed that there was ample, clear signage. People had their ID badges visible, and that was noted as helpful to know who to ask if you had any questions, on your way to the institution. And then once you arrived, that information desk was easily identifiable for further help. The entry and lobby itself felt warm and friendly, but also very busy and overwhelming, which the observer noted, really impacted how they were thinking about next steps and how they felt entering the institution. The journey to the destination, which was to find the clinic, there was no map to be had in the lobby itself. They felt there was confusion at the information desk. They kept trying to send them to the NICU, and the program is called NICU Grads. And so there was some confusion there. And also once they got there, but part of the problem on the way was that there had been a name change recently for the program. And so they were looking for a program that essentially didn't exist on paper, right? So the signage wasn't reflecting that recent change to program name. We also use the health literacy environment of hospitals and health centers, which grew out of work that produced the walking interview. The health literacy environment of hospital and health centers is less qualitative and more quantitative, right? So there's some yes, no questions, but most of them are on a scale, 0 to 4, typically responding to a variety of questions in a number of domains. Those domains included organizational policies, institutional practices, navigation, questions around culture and language assessment, around communication. So that sort of weaves in some of the work we talked about related to the SMOG, the PMOSE, IKIRSCH, the PEMAT. So that's a piece of the larger environment assessment, of course, is the information. And this is what we found. So we didn't do the organizational practices piece because we were looking at the clinic itself. And while it was really important, certainly to think about the clinic in context, we decided not to do it for several reasons. One of the reasons was that we, and our clinic director here, felt that we have greater control, right? Institutional practices down, we had control over. So that's where we started. So we looked at institutional practices, lots of components. We saw that overall, we scored a 44% on our institutional practices related to health literacy. And that comes from a variety of things we assessed, including institutional resources. And I mean clinic here when I'm saying institutional resources. What kinds of things were in the orientation, and what kinds of things were related to development of information, materials, structures, processes in the institution, and how were the expectations around health literacy. We also looked at navigation, right? That arrival, the wayfinding, was there staff assistance? How easy was it to navigate in the hallways? And this we saw we had a 60% score on navigation. For culture and language, we had 56%. There's many questions you answer, but not subdomains per se. And then for communication, we see that we looked at print materials, websites, forms, patient portals. So while there was a lot good going on, and the really nice thing about this assessment is that you can see it by domain, right? So you can see overall here, it's a 44%, but we can see resources, 80%, lots to look at, but, going in the right direction versus, the orientation to new staff, for example, and the way health literacy was emphasized or the training provided or the perspective provided, not so much. We also just wanted to touch on interview themes, and there's lots of ways that we can reach out and understand, I think, what staff and patients are thinking about. For the purposes of this project, we were able to do full interviews. And so we were really looking at facilitators for program participation and barriers to program participation. And this was across staff, families, and key informants. And that was intentional, of course, because we really want to see, do different groups think about this differently? Are there some things that are the same? And we really found that our facilitators were caring staff, and that was both inter-staff, right, and the way that folks talked about collaboration and the support of this interdisciplinary staff, and also the way that patients talked about how caring the staff was. And this interdisciplinary expertise came up over and over, again, from staff, as well as key informants, as well as families. It's funny to say patients in a follow-through clinic, right? We're talking about infants, but patients and families. So barriers to program participation, coming again, these are our very high level preliminary themes so far, but so far there's been a lot of talk about a lack of a systems focus, right? This integrated focus across levels. And we really saw that pan out, in our health literacy environment assessment, which allows us to look across levels. And there was also talk both from staff and from families about poor visit efficiency. And it was very interesting to be doing this at the start of COVID, right when we were bringing in telehealth and other things that maybe hadn't been done before, and thinking about that, as we talk about visit efficiency. So what would we say are our key learnings and next steps? So certainly we found that there are facilitators, lots of things that we're doing right as a clinic, right? But also really extensive barriers. Really quite a lot of things that are not facilitating the experience, and that really speak to a lot of the things that we see going on, a lot of that initial data that Jonathan provided about who's continuing to participate, that there's varying levels of family engagement, even if they participate and come to clinic, and a lot of data about areas that we can now address with very concrete pieces of that, right? That can feed into both the task force, who's going to have to make the decision about where we start, right? Because you can't do everything at once. And also how we're going to measure this. And we've decided that we're going to do that in a quality improvement fashion. And there are both quality improvement measures available from health literacy, which I've included in slides at the end, but also these assessments that we've showed you can be part of that measurement, right? Most of these assessments are quite low burden once you learn to use them, meaning they don't take days and days and hours, and we can use them, to see, has there been a change, right? Did this implemented change that we made to address X really have that impact, right? So what we also know is that this burden is unnecessary, right? All of these extensive barriers that we saw are really unnecessary, and we're making the process of navigating care even more complex. And the burden is falling on families, right? And taking this multi-level perspective with many different systems frames and thinking about health literacy as health equity and as a health equity tool, of course, just one part, but a very concrete part, really allows us to see where we can make some of those changes to reduce that family burden, to really look at the system's demand, rather than just saying, well, families should be able to figure that out, or families just need to learn this one thing, and then, things will be fine. So that all said and told, right, we're not optimizing outcomes for all high-risk infants, certainly. And so this task force that is undergoing right now, being set up to look at these data and all of our other systems level analyses to really drive these improvement activities and drive change, and knowing that all of these data will help create a plan. Again, this is not something, very overwhelming to think about all of this at once, right? But it allows us to really break it down and start tackling different pieces. So we're lucky enough too that the chief fellow, one of the chief fellows in pediatrics is taking on this project. And I keep mentioning all these different people and programs who are helping, not only because it's so important to acknowledge their time and work, but also that we've really thought about this across sectors and really as a collaborative piece, right? It's not just our clinic, but who might be interested? How can we get folks involved? One interesting thing too is the next step is that the clinic just moved. And so we certainly have to redo our environment assessment. Some of it is, we might suspect is similar, but there really is a whole new physical environment. And so understanding what that looks like, that's very much next on our list. And continuing to involve, right? A piece that we haven't been able to dive into too much today is that interaction and that involvement of staff, of graduate students, of current families, and really making sure that they're central to these next steps, right? So task force includes family. Any newly developed systems, processes, information materials are piloted with the task force, certainly, which includes family, but also further with family before it's implemented. So for example, we might choose, we don't know, but we might say, we're really looking, if you remember one of our data points that was quite low, our information materials and also in the health literacy assessment, the environment assessment was our referral process, right? And being an interdisciplinary clinic with kiddos who need so many different things, our referral process is crucial. It's essential to the work that we do and being able to do it well. Not only to them, right, but to our systems and our processes and our efficiencies. So we said we would tackle, review and revise that referral process. So really redevelop the process, really think about the navigation steps, adapt, readapt, adapt, create new materials, and then pilot it. Have the task force, then another subset of parents, and then really use a quality improvement cycle, as I said, a PDSA cycle, plan, do, study, act, to use the new process, to collect data and really to see, is this process any better? So overall, what we've learned certainly are that multi-level health literacy assessments are feasible. We can no longer just be looking at information, even as diverse as we might look at that, websites, talk, and other things. We really have to look across levels. We really have to think about how these information items are used, how the website is used, what we can provide, what other kind of scaffolding with providers, what ways do our processes and our operations, we could have the best referral document out there, but it really depends how we use it. It really depends, is the process clear? It really depends on our operations as a clinic, right? So also we learned doing it in stages. We didn't do this all in a month. Right? We used a process to do this over time. We involved many constituents, as we've noted, and we're looking at ways in which, these different pieces can address multiple barriers simultaneously. At the ways that doing some of this is going to address some issues with, that we want to address with racial equity, with health equity, with really applying a disability framework, with applying a family engagement framework, right? And seeing this as a crucial part, right? This is a frame, it's operating, it's how we do business, right? Going forward, which then reduces in the future, hopefully, right? Every time now we create a new material, every time we create a new process for this new piece of the clinic, right? That's really focusing on some unique genetic issues that kids might be facing. We're applying these frames from the beginning, right? So we're gaining efficiencies there as well. So I want us to think about, as we dive into discussion, Jonathan and I talk about this all the time, what are we going to do today in our learning? What are we going to do tomorrow, in 1 week, in 1 month? And that there are lots of ways that we can do this, and it takes practice, right? It takes practice talking to people, re-talking, reintroducing, thinking about it in a different way, and that we can do that both as professionals and we can do that as community members. We can vote, right? We can advocate for clear signage. We can be just talking about the connections between literacy and health, or asking questions in our community engagements around how literacy is being considered. We can take advantage of this conference, which is amazing and free, and thank you, thank you. And also the listserv. I don't know how many of you are on this listserv that IHA runs up here. It's a really wonderful moderated listserv by our moderator today, Julie. And also so many trainings, resources, conferences, you know, that we can maybe start attending together with colleagues. One of the reasons we've asked you to comment in chat is to start seeing, you know, people who might be interested in talking more about this, because maybe there isn't someone else at your institution. So there's ways to sort of start that conversation with the brown bag at your institution, tell people about what you know, starting to think about, but also connecting with people, you know, in the chat and through the conference. We've also provided extra resources at the end of these slides, a lot of them, on all the different things we touched on. I also want to offer to be in touch with me, as I said, you know, welcoming that and the conversation with Jonathan. But I have graduate students every fall, and I work into their assignment that they are highly encouraged to work with folks who want their information materials, website, etc., assessed, as well as the health literacy environment. And that can look like lots of different things. And I really encourage you to email me, and I can get you on that list so that students, you know, can be thinking about doing some of this work with you. So with that, Jonathan and I say thank you very much, and we're excited to have some time for discussion and to be continued. You know, this isn't the end. We really do welcome that continued discussion and inquiry. So thank you.
Thank you so much, Lindsay and Jonathan. That was excellent, and I hope that we have some questions. No questions came through yet, so there's nothing specific to answer. Although actually one just came in. How, if at all, could you envision these assessments could be used in a public health department or public health agency at the local, state, or federal level? That's a great question. So
I'm happy to take a start, Jonathan, or do you want to?
Sure. Go ahead.
So I'm so glad you asked this question. Yeah. So I actually am just finishing a manuscript where we're talking about this particularly for oral health and oral health organizations. I think most of it is applicable across. And really thinking about, you know, if it's a clinic, you know, a dental clinic, is it a public health organization? Is it a state association? Is it a national association? And the different ways that folks can do this. So it's certainly looking at information, right? And assessing the information that a public health agency puts out. I think it's also assessing, you know, with the health literacy environment assessments, you can use that for a public health department, for like a state public health department or a city public health department or a department within it. And really just thinking about that as this was a clinic, right? A clinic that's providing health services, but really every department, for example, within a public health department is providing service in a way, right? It might not be direct service like a clinic, but there are services, whether it's providing data, whether it's providing information on, you know, how to deal with whatever issue it is in that department, and really looking at the information provided, the processes, you know, how does the department operate? Because I think we also need to remind ourselves that the average US adult works in our department and works in our institutions as well. So our professionals are also average US adults. You know, and folks maybe who haven't experienced, you know, whatever it is that's happening in the department before. So I'm happy to be more specific, but my general response is that all of these assessments can be used in any type of organization, and it's really thinking about sort of your patients or your participants in a little bit of a different way.
Great.
And I guess, if I might just add, you know, again, being so new to this world, right? Sort of my area has been on, you know, children and chronic illness and disability and the health literacy piece. I'm learning so much, and I think one of the things that has really struck me is really thinking about what is the goal of, particularly when we're thinking about the materials, right? Is it to communicate information, or is it to really inspire action, or is it task oriented? And I think sort of applying, it's one thing to sort of think about, oh yeah, health literacy, that, we should make sure that it's written in plain language, and then it's certainly important. But is it actionable, right? Is this piece of information, is this text, is this item really going to do what we want it to do? And using the tools in that way, that has been so eye-opening to me, right? Thinking about, oh yeah, I actually want this to prompt a task. Is that actually, is it going to achieve that? And really using the tools and thinking about the population and their response, and thinking about, is it serving their needs? So I just think those high level things are definitely applicable in public health. Yeah.
Absolutely, agreed. And another short example I'll give is we've done this also. I talked a little bit about oral health, and we were really talking about it across levels and ways to be thinking about health literacy and what folks can do, for a state dental association, for example. But also I did this recently. It came out of work that we did around serious mental illness and literacy. And we did this kind of assessment, much briefer, but it was for a shelter that provides housing, and all of their guests are enrolled in some kind of substance use and misuse, et cetera, right? And we know that when folks are enrolled in rather have stable housing, they have much more success in staying in treatment, managing treatment, et cetera. And so there was a question that came up around compliance, essentially, right? And this comes up all the time: compliance, adherence. And for the shelter, it was around sticking to the rules that they had signed in a contract, and then being asked to leave because they weren't sticking to those rules. And there was a lot of question from staff after receiving our study results, which they participated in, were really about literacy and mental health. But they were saying, maybe this non-compliance, quote unquote, is actually us not doing a good job of providing the information in an understandable and actionable way, of not have both physically in the shelter as well as the contract, right? This agreement contract that folks had to sign.
Thank you. I just wanted to squeeze in one more question before we
Great.
do our just final housekeeping.
Sure.
Carol asks, what kinds of resources, human and funding, did you have to do this project?
It's a great question, always important. So Jonathan, you want me to start?
Yes.
Do you want to start?
Yeah, I was going to say, do you want to describe the fellowship, and then I can talk about the
sure.
grads resources? Yeah.
Right. So many, like so many projects in public health, right? A little bit from here, a little bit from there. There was definitely some in-kind services, right? Jonathan was in kind, and he can talk about other staff and how he covered some new staff time for things like this. I was awarded a fellowship, which was for a family member of someone with disability. And I used that I went to Jonathan and said, hey, what do you think? And so we were able to use that. It certainly didn't cover it all, but that really got us started. Also, it was a lot of in-kind sort of exchange, shall we say, right? So for the interviews, I trained a cadre of graduate students to do that qualitative analysis, which is above and beyond what the clinic might have typically done. But it allowed me to provide them with training and mentorship in a skill that they wanted to build, and at the same time providing this service to the clinic. And then as we mentioned, and as I invite you to write me about, students in my courses provided a lot of the assessment for both information items as well as the environment. So it was certainly lots of pieces cobbled together.
Okay, thanks. We have one last question, but I think I'm gonna hold off on that. We will answer that. We'll get Lindsay and Jonathan's answer to that and post it on the discussion list. So Deb, you can find that later, but I just don't want to keep people over time, and we just have to sort of close out with the final housekeeping. So if you can go to the last slide. Yeah, so again, please visit this this link, ihaforhealth.org, to learn more about the conference. We have a great conference coming up, and we hope that you will join it all. And the next pre-conference session is scheduled for May 19th. It's addressing health disparities, what health partners and adult educators can do together. The speakers, I know all of them, and they are fabulous. So so please come to that. Again, we will answer the last question in the discussion list, and we can have some discussion about it too. If you have other things like the last question they posted about, you know, what do you need to do to make this better in your organization, we can discuss that on the list. So so thank you so much, everyone, for coming to this. Thank you so much, Jonathan and Lindsay, for this fabulous presentation. It was really interesting, and I hope that people can take it and use this information to make some changes at their place. So thank you so much, everyone. We will see you at the next webinar.